Yeah, is this
Yes, ma'am.
audible? Yeah.
It is
I'm audible.
audible and visible.
Okay. So I would like to thank the organizers and Borges Madam for allowing me to present the normal histology and grossing of the breast that we'll be covering today. So in October is the breast cancer awareness month, and I am very pleased to be inaugurating the breast cancer topics for this month with the normal histology and grossing. And these are my disclaimers. Now, breast, as we all know, is a modified apocrine gland which lies from the lateral sternal border to the mid-axillary line from the second to the sixth rib, and it is composed of main duct branches which repeatedly divide to form number of terminal ducts, each of which ends into a lobule which contains multiple acini. So now we have to remember that clinically, radiologically, grossly as well as microscopically, it is difficult to delineate where one lobule ends and the other begins. There are no actual anatomical distinction or divisions between the various lobules, and so we artifactually divide the breast into 4 quadrants by passing lines through the nipple. This yeah. So the functional unit of the breast is called the terminal ductulo-lobular unit, which is basically, you can see that is a terminal ductule which is ending into the which is dividing and forming into ending into multiple acini which are surrounded by stroma, and the whole system, that is the acini with along with the ductules and the main ducts, are composed of a bilayer of inner luminal epithelium and an outer basal myoepithelial cell layer which rests on a basement membrane and is surrounded by stroma. So this is the hyper view of the terminal duct with the acini, which all show the similar lining of epithelial cells, which are small cuboidal to columnar cells with moderate cytoplasm, round nuclei with fine chromatin, and surrounded by clear or flattened cells which have dark hyperchromatic nuclei. These are the myoepithelial cells. And it is important to identify this bilayer, because absence of the second layer, that is the myoepithelial layer, signifies presence of an invasive carcinoma. So we use certain immunomarkers to identify these both the layers. For the epithelial cells, we use generally CK7, and because these are the epithelial cells are responsive to hormones in the body, they show heterogeneous estrogen and progesterone receptor expression. While the myoepithelial cells, that is the outermost layer which also forms the contractile meshwork, is positive for basal keratins such as CK5, 6, 7, 17, 14, and also for myoid markers such as smooth muscle actin, calponin, SMMHC, and in addition also basal cell markers such as P63, P40, S100, CD10, etc. And as I said, the loss indicates presence of invasive carcinoma with certain exceptions. Generally, we use one nuclear marker and one cytoplasmic marker to identify these myoepithelial cell layer.
Ayushi,
Yes, ma'am.
can you use a laser pointer if you can? Because sometimes you can't see your cursor, if it is possible.
No, ma'am, I don't have the laser pointer with me at the moment.
No. Can you right click your mouse? See if you get a menu which says pointers. Does it?
Sure.
Yeah, and there is a laser pointer.
Yeah, is this visible, ma'am?
Yeah, I think it's a little better. Thank you so much, Ayushi.
Thank you so much, ma'am, for guiding me in the Mac again. So the second component of the breast, besides the inside the ductal unit, is the stroma of the breast, which is usually hormone positive, estrogen progesterone receptor positive, and you have two types of stroma. That is the interlobular stroma, which surrounds the main ducts, and that the basic structure of the terminal ductulolobular unit, which is dense and more collagenous and fibrous, and we have the intralobular stroma, which surrounds the acini, which is loose, little bit myxoid, and so has also inflammatory cells. The other normal histology anatomically important structure is the nipple areola complex, and as you know that the nipple is the area where all the large ducts, the large ducts drain out onto the skin, and in this the terminal duct, when they approach the skin, they can form large dilated sinuses, or in a normal resting state, they can also have this kind of serrated appearance. And the we don't have pilosebaceous units in the nipple areolar complex in contrast to rest of the skin, but we do have a large number of sebaceous glands that drain directly onto the skin or into these lactiferous ducts. The stroma of the nipple is very densely hyalinized and collagenous, and the nipple areola is separated from the underlying subcutaneous breast tissue by a layer of smooth muscle bundles, that is the contractile layer of the nipple. And it is important to identify this and not mistake it for nerve bundles for one. And also, if there is any tumor that is infiltrating this muscle layer, it indicates that this is the stroma or the dermis of the nipple is involved. So it kind of forms a cutoff point. And this also helps to identify the nipple areola or areolar skin from the rest of the overlying skin where this layer is absent. And the rest of the skin, of course, looks like skin anywhere else in the body. So with this we begin the grossing of the breast. So the first we have to know what all type of variety of specimen we can receive in breast grossing. For clinically palpable masses, usually the surgeon, depending on the size of the mass, the surgeon can undertake an excision, which is also called wide local excision or lumpectomy. And in cases where the mass is impalpable, clinically not identified, but radiological abnormality or calcification is identified, then various radiologically guided procedures such as wire localized excision or sonolocalized excision can be undertaken. And in such cases, both these type of specimen, because they are excisions with wide margins, the status of the margins is the most important. And in case of positive or involved margins, you might have what is known as margin revisions or re-excision specimen. In cases of nipple discharge, you can get specimens of microdocectomy. And in case of larger tumors, generally a mastectomy can be taken, or it can also be a prophylactic mastectomy. Now, the mastectomies can be simple, modified radical, skin sparing, or nipple sparing. These I'll just explain in a moment, depending on the extent of excision. Then also you can have completion mastectomy, whereby the patient has undergone a wide excision or even a mastectomy earlier. And in these days, with increasing cosmesis, you can also have reduction mammoplasties. So these are the various types of mastectomy. You can this is a simple mastectomy whereby you have an ellipse of skin and without any axillary tail, and generally the plane of excision is through this prepectoral fascia. Whereas in a modified radical mastectomy, the axillary tail is generally attached and pectoralis minor with some amount of pectoralis major may also be excised. While in a radical mastectomy, the plane of cleavage is through this, it includes the pectoralis minor as well as the whole of pectoralis major. Regarding the other types of mastectomy, this being an MRM, if the tumor is away from the skin with increased cosmesis available these days, more skin sparing surgeries whereby only nipple and small amount of skin is included are being used. And even if the tumor is far away even from the nipple, then even the nipple is spared. So this is known as a nipple sparing mastectomy, whereby the skin can then be preserved for cosmetic procedures. So the procedural selection depends on a variety of factors, including patient factors, the tumor factors, the receptor status, the availability of the adjuvant therapy, and of course, patient choice. So general principles of grossing remain the same as in rest of the body. However, there are certain ASCO-CAP recommendations because the pathologist has a duty not only to report on the extent of the tumor, but also biomarkers, which are important prognostic and predictive markers. So for that, there are certain recommendations by the ASCO-CAP. The cold ischemia time should be less than 1 hour. That is the time between when the tissue is taken out from the body to the time it is put in formalin. It should be less than 1 hour. And the duration of fixation should be not less than 6 hours and not more than 72 hours for appropriate evaluation of the biomarker status. The amount of fixative should preferably be 10 times the volume of specimen, and at the very least should be at least 4:1 of the volume of the specimen. And before you begin grossing, it is very important to have an institutional checklist whereby you can go through all the available relevant information should be there in front of you before you begin grossing, which includes the clinical history, the site, laterality, location, the size of the tumor, relevant radiology, any previous biopsy report and biomarker status, any prior therapy if the patient has received, the type of specimen, the type of node removal, and all the list of specimen that is being sent to the lab, and any clips, sutures, or markers placed in the specimen. So you should develop an institutional checklist where you can go through all these findings before you begin the actual grossing. Yeah, so with this, we begin the first specimen, that is a lumpectomy, wide excision, also known as the breast conservative surgery. Now, the aim of this kind of surgery is to reduce the tumor burden while maintaining the cosmetic appearance. And in such specimen, the most crucial, as I said, is the status of the margins. Now, if you imagine the breast lump tumor as a and the lumpectomy specimen as a globe, if the tumor is at the center, the number of areas or surfaces that is surrounding the tumor is huge. So it is better, instead of as a globe, you should imagine the kind of orient the specimen as the form of a cube with the tumor at the center. And now, instead of having innumerable surfaces to measure or check the margins, you have basically 6 surfaces in a cube, and then you can sample these surfaces in a limited number of sections. So this is a specimen of lumpectomy. For orienting these 6 surfaces, as I said, you need to be the specimen to be oriented in minimum 3 directions. Generally, by convention, short superior, long lateral, and usually black thread or skin is kept in the as an anterior marker. And with the help of these 3 orientation helps, you can orient the specimen to superior, inferior, medial, lateral, and anterior, posterior. And after you have oriented the specimen, you have to ink the specimen in all directions. You can use multicolor inks, or you can use simple black India ink or camel ink also, depending on your institutional practice or availability of resources. What is important actually is to remember that the ink, first when you apply, it should be kind of gently applied and should not be kind of slap happy manner. You should not slap on the ink, because the breast being a very soft, fatty, lobulated tissue, if you put the ink in a heavy handed manner, it will penetrate the fatty lobules and cause false positive margins. So gently tap the ink, and it is important to remember that some amount of guesstimate may be required, that where one margin is ending and the other is beginning. However, if you have a well oriented tissue, you are generally able to make out which margin is which. So now you have a specimen which was oriented, which you have inked in appropriate manner, and now you have to slice the specimen. So you have to, the general method used is, because most of the tumors have the longest dimension along the medial to lateral axis, the slicing is usually from medial to lateral in a sagittal fashion, or along the longest axis of the tumor, and the slices should be 5 mm thick. The variation of this is that you can if the tumor is anteroposteriorly largest dimension is there, then you can kind of slice it in a superficial to deep plane, similar to what is done in the prostate. But most by convention, we slice it in the medial to lateral direction. Another method is, for very small specimen, you can also give a cruciate incision through the posterior aspect, and in that manner you can open up the specimen in the form of an orange. The advantage of this method being that in taking limited 4 sections, you can kind of give all the different margins in limited 4 sections, as well as the tumor sampling. This is especially useful for smaller specimen, but as I said, in this kind of specimen, you will have to use multiple inks rather than a single ink if you use this kind of incision. And after the specimen is serially sliced, you place cotton swabs between the various slices in a bread loaf manner. You place the cotton swabs, which should be pre-dipped in formalin to prevent sticking to the breast fat. And as I said, volume of fixative should be at least 10 times. So this is my first MCQ.
So I'll read out the question for the students. For wide excision, all of the following are true, except option A, serially section the specimen at the deep surface from medial to lateral or lateral to medial. Option B, do not cut all the way through. Option C, all cassettes should be no more than 50% full of tissue and no greater than 3 mm in thickness. And option D, even in case of discrepancies with the orientation or laterality, grossing should not be delayed. Students may please answer in the chat box. So most of the students are answering option D.
Yeah, so I'm glad everyone is listening. I have mostly explained all these points that we have to serially slice the specimen on the deep aspect from the medial to lateral or lateral to medial. It does not make a difference. We should, when we are slicing in the initial cut for fixation, we should not cut through and through, and we should cut so that we can maintain the orientation even after fixation. And of course, in this is a standard protocol, all cases should not be more than 50% full and or have tissues more than 3 mm. However, it is important to remember that in case of discrepancies with the orientation or laterality, where what is marked and what you are seeing are different, then grossing should not be proceeded further, because once the margins are disturbed and you have taken some kind of margins which are not matching the clinical markings, then it is very difficult to go back and correct the margins again. Many times you will end up not knowing which margin is close or positive if you go ahead. Hence, it is, if any kind of discrepancy is there, you should immediately call the surgeon, and in this case you have to wait till the orientation is proper. If the specimen is getting very delayed, like beyond, if this fixation time will go beyond 72 hours, then you might take a single section of the tumor only without disturbing the margins for biomarker evaluation if required. Other than that, in any kind of discrepancy with orientation, please call the surgeon and discuss the margins before proceeding further. So after the specimen is fixed overnight, we continue with the grossing. That is, we first of all start with the measurement of the specimen in 3 dimension with the skin dimensions, if any. And for the tumor, we have to give the size, which is the most important, location, the distances from the margins, and any additional lesion with distances from the main tumor. We also have to note presence of any kind of calcification, clip, scar, the tumor, also color, consistency, appearance, what it looks like, or is it appearing, the margins of the tumor, edges of the tumor, infiltrative, non-infiltrative, encapsulated, all that has to be described. The important part here is the T size. The gross or microscopic evaluation of the measurement of the tumor is the gold standard, and the single largest dimension of the largest invasive carcinoma we have to measure to the closest mm, because the largest dimension is the crucial factor for the TNM staging, and we stage the tumor T1, T2, T3 depending on the grossly identified size or microscopic size of the largest tumor. What do I mean by the largest tumor? We have to keep certain factors in mind, that the size has to be measured only of the invasive tumor, not of any surrounding DCIs. Sometimes this can be difficult to differentiate on gross. However, we should attempt to identify DCIs separate from invasive carcinoma. And when there are multiple tumors, the largest tumor size is what is used in AJCC TNM classification. Now here we have to remember that if the other tumor foci are more than 5 millimeter away, then they are considered as separate tumors. However, if they are within 5 millimeters, they are considered part of the same tumor. Why? Because it is in tumors in the body can be in 3 dimensions, and when we have taken slice in 2 dimension, it might happen that where we have cut the slice, we are seeing what we see on gross as two different tumors. If it is taken by convention that if they are within 5 millimeter and they have the same histology, then they are part of the same tumor, possibly with pseudopods in different directions. And if it is more than 5 millimeter apart, they are considered as separate tumors, and then the size of the largest tumor only has to be taken. Now coming to the sampling of the margins. So we can take margins in different ways. They can be either perpendicular or radial margin, and tangential or shave margins. Depends on the distance of the tumor from the margin. If the tumor is less than 1 centimeter away, we should definitely try to sample it in a radial manner, so that in the section we have the ink margin as well as the tumor in the same section, and we can microscopically measure the distance or identify involvement of the margin with the tumor. However, if we take tangential shave margin, that should only be done with the tumor is far away from the margin, at least 1.5 to 2 centimeter. And the difference in evaluation here is crucial. So we have to know what kind of margin we have taken, because in a radial margin, you will always have a tumor along with the ink, while in a tangential or shave margin, if there is presence of tumor, it is considered a positive margin regardless of the ink. And if there is no tumor identified, then it is a negative margin. So for example, here in this specimen, this margin is relatively far off, but these two margins are very close to the ink here. So when we take the section, we should take radial section so that we can, on the microscopic evaluation, we can actually measure the distance of this margin from the actual ink. If we end up taking something like a shave margin in this, we can either artifactually create a positive or create a negative margin depending on the thickness of the specimen that we have taken. So it is better in when that margin is close to take in a radial manner so that microscopic distance can be estimated and measured. And how much to sample? We should try to take at least one section per margin, and if a tumor is approaching some margin, we can take more sections of that, so that in successive different slices we can see in which point the tumor might be reaching the margin. Again, we have to remember that if we have ink with multiple inks, then we can put a section with multiple color inks or multiple margins in the same block. However, if we have used a single color ink, always we have to take only one margin with the ink side in the block. And the significance of margin being that, of course, when the margin is involved, it is a predictor of local recurrence. And the definition of positive margin is any tumor on the ink surface grossly or microscopically. It is optional to report the approximate extent of margin involvement, whether it is unifocal or multifocal or extensive when it is carcinoma is present over a broad front of more than 5 mm. Also, there is a practice in most of the institutions to report close margins, that is within 5 mm of any margin, suppose lateral margin or medial margin. If the tumor is 2 or 3 mm away, it is documented in the report. It may impact the surgeon's decision for revision or mastectomy, but it is not a positive margin. Close margins are not positive margins. Only tumor directly involving the ink surface is considered a positive margin. However, for DCIS, the margin of adequacy is different. A DCIS 2 mm away from the margin is considered adequate. If it is closer than this, then it is considered a margin involved by DCIS by surgeons. Also, we have to remember that due to the weight of the specimen or flattening of the specimen may lose height. So some amount of margin error might creep in. We should try to account for that. So this is my second MCQ. Jayati, should I proceed?
Option A, image 1, but 40% thought it is option C, that is both.
Okay, so here the answer is option A, that is image 1. As you can see here, the tumor is directly involving the ink. That I said is the definition of a positive margin. Option 2, that is second image, is wrong on two accounts. First of all, we can see that the tumor is not involving the ink margin. It is at some little distance away. It is not actually sitting on the ink or the cauterized surface. So it is some distance away. And second thing is that this is not a tumor front. This is a lymphovascular embolus. So lymphovascular emboli, even when at the margin or involving the margin, is not a positive margin. Only broad front of the tumor that is involving the margin is a positive margin. And if there is any doubt, you can always do markers, endothelial cell markers, to check whether it is a lymphovascular embolus or it is a tumor front. So involvement of the lymphovascular embolus, even if it is at the margin, is not considered a positive margin. Then we come to how much of the tumor to sample. So you have to slice the tumor in the longest dimension. If this is the longest dimension, we should submit the slice with one grid of the tumor. For T-size reconstruction is needed for microscopic examination. I will tell how this is done. And you have to also, if the at least one full grid has to be submitted of the largest cross section. And if the tumor is present in additional slices, then at least one section from the additional slices with minimum at least 4 sections of the tumor. If the tumor is less than 2 centimeter size, you should submit it entirely. And we should also make a grid diagram on the accompanying form and number the sections sequentially so that we can reconstruct it when we are seeing it on the microscopic examination. So, and also we have to take sections. When we are taking the tumor section, we should always remember to take some amount of adjacent uninvolved breast along with the tumor to document presence of EIC, lymphovascular emboli, and uninvolved breast ducts to serve as control for estrogen and progesterone receptors. Why? Because the definition of extensive intraductal carcinoma is presence of DCIS in more than 25% of the area within the invasive carcinoma, as well as DCIS should be present outside the surrounding area of invasive carcinoma. Sometimes we see sections taken by residents where they have taken the section only of the tumor without any of the surrounding breast tissue. In such cases, then we will not be able to identify if there is extensive intraductal component, because this part of the definition we will not be able to evaluate. Also, when you have extensive DCIS on microscopy, you have to take multiple sections. Preferably, the entire DCIS area has to be sampled to identify small areas of microinvasion, which will again make it a presence of extensive intraductal carcinoma. And this is EIC is basically a very crucial factor for recurrence. And for this, as I said, the tumor sections need to be taken with the adjacent breast. Similarly, presence of lymphovascular emboli is a significant predictor of local and distance recurrence. And so, and the criteria for diagnosis of LVI is also that it should be present outside the border of invasive carcinoma, at least more than 1 millimeter away. So, if again the section has been taken only of the tumor without including any surrounding parenchyma, these factors are difficult to evaluate. So once we taken the, we have examined the gross and we have made a taken the sections, making a grid diagram. We should identify the presence of margins in the diagram, which how close they are located as per our gross evaluation. And if as I said, if some margin is very close to the tumor, then we can take more than one section from that margin, so that we can say where it is involving the margin. And what about T-size reconstruction? Suppose this is the grid. When we have taken the section, we have made the diagram of our gross impression of the tumor, and it is divided into two sections. Now, when we have the microscopic examination, the orientation of the sections might be different from what we gave it during the grossing. So, when we can, with the help of the grid diagram, we can reconstruct the tumor in the adjacent slices, adjacent sections, and orient it in such a way that we can give the microscopic distance of the tumor, which might be different from a gross impression. So, we can cross-check whether the gross distance is given correctly, and if there is any difference in the measurement, we should give the final microscopic distance, and this is assisted with the help of our grid diagrams. So, always we should take grossing. When we should give a complete cross section of the tumor in the form of a grid with labeled grid diagram. Now, the other specimen of limited resection is wide local excision, which is done for non-palpable abnormalities, which are identified on radiology. In this, a wire is inserted into the lesion under mammographic guidance, where the radiologist is finding the abnormality, and then the surgeon excises the specimen with the wire in place, the tissue around the abnormality. So remember, the surgeon cannot see the abnormality. This is identified only on radiology. So with the help of this guide wire, the surgeon excises the tissue from the breast, and it is kept, the specimen comes to us with the guide wire in situ. So it is, we have to take it again to the radiology department to confirm whether the wire is still incorrectly in place of the abnormality, and then we serially slice the specimen from medial to lateral side, and this time we do full thickness slicing and orient the slices in a sequential manner in the tray, and then the radiography is done again to confirm whether which slice of our grossing is the abnormality in. In that slice, we again mark, we identify any lesion if we are able to identify on gross. Sometimes we might, what is not evident to the surgeon or non-palpable, we might not be able to see on gross, but if we are able to identify, we should again take the size and the distances from the margins. Then the specimen is fixed in this kind of serially sliced manner, so that we can reconstruct the specimen if required for assessing the margins. Once the specimen is fixed, again the sections have to be taken in a grid where we have to, the slice with the radiographic abnormality has to be submitted entirely, and if we are identifying any gross, we should mark the area where we are finding abnormality in our sections also. This brings us to the next specimen, that is mastectomy. Now, when we receive a specimen mastectomy, we should first orient the specimen. If there is presence of axillary tail, it is of course very easy. The axillary tail is of course laterally and slightly superiorly oriented. But if the axillary tail is not attached, generally the area should be marked by the surgeon that this is the lateral side. We should grossly palpate the presence of the lesion and examine the skin and NAC carefully for any kind of scar, ulceration, puckering, retraction, inversion. Purity orange is more of a clinical phenomena, but sometimes in extensive purity orange phenomena, we can identify it on the gross examination also. Presence of prior biopsy, suture or scar site is very helpful for us to identify that the tumor is most likely lying below in this area. We all have to note the dimension of the breast and the skin. Now, these are the various skin abnormalities. As I said, you might have in some extensive cases of purity orange, you might identify it on gross. Fortunately, we don't see this kind of specimens very frequently these days, but once in a while, yes, this kind of fungating gross, large appearing tumors can also be identified. And these are the various kind of abnormalities you might see in Paget's disease, that is slight amount of ulceration, or you might have more extensive disease with scab formation or complete destruction of the nipple altogether. Now, once we have identified the skin and the abnormalities, we should invert the specimen and ink the base or the posterior margin. We should not ink the axilla. The axilla may be separated at this point. And we have to serially slice the specimen at 1 centimeter intervals on the posterior surface. Being a bigger specimen, more fatty specimen, the slicing thickness is kept at around 1 centimeter. And again, we have to insert cotton swabs with dipped in formalin in between the various slices in the bread loaf manner. And again, fix the specimen in adequate amount of formalin. Once the specimen is fixed, we can extend our cuts to the full thickness and arrange it again in a sequential manner, so that we can identify the tumor and the slice it is involving. Again, measure the distance and location of the tumor and the size of the tumor with the distance from the base, skin, and the areolar complex. And because mastectomy is generally done if the tumor is multifocal, we should also try to identify any other lesions present in the breast. The section from the nipple area complex is by convention usually taken in a longitudinal or coronal slice to submit the maximum area of the skin and with the underlying ducts. This is my third MCQ.
So The question is regarding mastectomy, all of the following are true except option A, medial lateral dimension of MRM includes axillary tail. Option B, if axillary tail is present, there's no need to ink axillary tail tissue. Option C, ink mastectomy prior to removing the axillary tail. And option D, even if no axillary tail is present, try and palpate the upper outer quadrant for lymph nodes. So most of the students thought it is option A, but there were a few C and D as well.
Okay, so in this, yes, option A is correct. If you have seen the pictures properly, yes, I did show that the axillary tail is present. There is no need to ink the axillary tissue. We have to ink the mastectomy prior to removing the axillary tail so that the base can be properly inked, because that is a fascia that can be more easily identified. And even if no axillary tail is present, we should try to palpate. Even if it is a simple mastectomy without axillary tail in the specimen that is sent, you should at least try to palpate and identify any kind of nodes that might be present in the upper outer quadrant. And what is wrong is that the medial lateral dimension includes axillary tail. No, the medial lateral dimension of the MRM should include the MRM only, and the axillary tail measurement is not important in such a situation. So just to show what kind of gross appearance various lesions can have on the gross examination, we can, this is the way DCIS appears, especially the comedo type DCIS with calcification. You can have multiple nodules, you can have chalky white calcified areas, or you can have necrotic material extruding from the surface. Also, you should remember that most of the stellate lesions in the breast are malignant with few exceptions, and most well circumscribed or lobulated lesions in the breast are usually benign, with the exception of Phyllodes tumor and several tumors like medullary carcinoma, interductal papillary carcinoma, mucinous carcinoma, etc. And if it is an encapsulated lesion with slit-like spaces, this is of course a fibroadenoma. While if you have a tumor which may be well circumscribed but unencapsulated with pushing margins, very fleshy appearance, it is more likely to be a sarcoma, likely Phyllodes. This is what an invasive carcinoma would look like, with heterogeneous lesion with ill-defined margins, presence of necrosis, and fibrocystic with presence of cystic appearance and little bit of homogeneous appearance. However, in some instances, fibrocystic disease can also appear very irregular and appear like infiltrating. However, in this situation, most important is palpation. Fibrocystic disease is generally rubbery, while invasive tumor is quite hard. So, in this situation, in this kind of specimen, our resident, with the help of palpation, was able to identify a small focus of invasive carcinoma in an otherwise extensively fibrocystic tumor, fibrocystic breast. Now, as I said, mastectomies are generally for generally done for multiple lesions. So we should also try to identify if there are multiple other lesions which can be multifocal when the tumor is, as I said, more than 5 mm apart, or multicentric when it is more than 5 cm apart or different quadrant. This factor is important because this indicates one of the worst prognosis when it is multifocal or multicentric, and it is required for planning of the radiation boost. So, in multifocal tumors, how do you identify that the tumor is actually multifocal and not pseudopodes of the same tumor? One definition, as I said, is presence of more than 5 mm apart, but you also have to take sections of the intervening parenchyma. And how to do that? If the tumor is more than 5 mm apart, but still very close, you can take a section in which both the tumors are present in the same section, but an intervening parenchyma you will be able to see in microscopy. In this kind of section, it is important to include both the lesions that you are thinking, not just one of the lesions. And if the tumor are like more than 1.5 cm apart, you can take the intervening parenchyma in a perpendicular manner through and through between the two lesions. And how will that help? So, if you have taken the section in a perpendicular manner and on microscopy there is no invasive tumor, then this is staged as multifocal disease. That means these two tumors are separate. However, if it is present pseudopodes of the same tumor, and you on taking the sections in the intervening tissue through and through the middle of both the lesions on the grossly identified lesions, and microscopic identifies an tumor in the intervening tissue, that means the whole tumor is connected, and then the final T size on microscopic reconstruction will be the dimension of the first tumor, second tumor, as well as the intervening tumor. So the final T size after you have seen the intervening tumor section will become quite big. And then, of course, having a implication of prognosis. And how much of the mastectomy to sample? Again, you have to try to take the tumor in the largest dimension in a cross section in a grid manner, and you should try to include, of course, the adjacent breast, and base also should be taken as far as possible in the radial direction. If the tumor, generally the only margin in a mastectomy taken is the base. However, if the tumor is very close to either the superior, inferior, or medial lateral margins, then you can identify that on gross, ink that margin and take that also. But in general, most commonly, the only margin that is required in a mastectomy is the base. Also, you have to take sections of the NAC and the overlying skin, and if there is any scar, you should try to take a section through the overlying skin scar. So in skin sparing mastectomy, there are additional margins because the overlying skin has been removed here. So in this, only the small sliver of the nipple with the surrounding skin is there. You should divide the specimen into two with a line passing through the middle of the nipple, and this surface above is called the anterosuperior and this anteroinferior. So in the skin sparing mastectomy, you will have three margins. One is the base, as we take routinely. One will be the anterosuperior surface and the anteroinferior surface, and you should give the distance of the tumor from all these three margins as well as sample them. The three soft tissue margins will be sampled. Similarly, in a nipple sparing mastectomy, an additional margin that is there is the retroareolar margin, where the tissue has been the nipple areolar complex has been removed. Sometimes you can have an NAC undershave that is sampled separately by the surgeon while doing the surgery. From where they have cut the nipple, and this can be examined in the frozen section or in the routine processing. And you could, if we have received the skin nipple sparing mastectomy with a stitch mark, we can take the ink this area and take serial slicing from this area. If any of these sections is positive or contains tumor, the surgeon may decide to revise the surgery. Now, a completion mastectomy is usually done following an incomplete excision in the wide local excision, and we have to check the history to check if the margins of the wide excision have been reported positive when we receive this kind of specimen, and which margin has been reported positive. So, on gross examination, we will see a kind of cystic cavity lined by hemorrhagic material or granulation tissue, fat necrosis, or area of scarring. We should check the overlying skin for which should show a scar, and we should take a section from the scar to see of the involvement of the scar tissue by the tumor. And underlying the scar, we should identify the cavity. If we are not able to see the cavity, we should take the sample the area below the scar in entirety, the fibrotic area. And the whichever margin has been reported positive from that particular area, we should try to take more sampling. General recommendation is to take 2 times the largest dimension of the cavity. That is, if we have 5 centimeter cavity, we should try to take at least 10 cassettes, and rest of the grossing is as usual to mastectomy. So this is my next MCQ.
Following is true about staging of nodal metastasis in breast cancer. Option A, intramammary node involvement is not staged. Option B, supraclavicular node is staged as distant metastasis. Option C, ipsilateral internal mammary node is staged as regional nodal metastasis. Option D, all of the above. Option E, none of the above. So most of the students thought it is option D, all of the above, but there were a few option B, A, and C as well.
Okay, trying to go to the next slide. 1 second. I'm not able to move to the next slide. Just 1 second. This request for annotating are coming in middle, and
Please not ask for annotation request.
can you decline the request from your end, Jayati?
I can't see any annotation request from my end.
Because this is making the presentation hang. Yeah, now it is gone.
Gone? Okay.
So the answer is actually here is the only thing true in these three statements is that ipsilateral internal mammary node is staged as regional nodal metastasis. Intramammary node involvement is also staged as N1. It is part of regional, considered as part of regional axillary node. Supraclavicular node is not staged as distant metastasis. It is a regional node. So I put this question just to give you an idea that which we should be aware that which all nodes are regional nodes and which are considered distant metastasis. So the level 1 axillary nodes are the nodes that are lateral to the pectoralis minor muscle. The nodes that are medial to the pectoralis minor are level 3, that is apical nodes, and the nodes that are in between the pectoralis minor and the major, that is behind the pectoralis minor, are what are called as level 2 nodes. Besides this, the supraclavicular and infraclavicular nodes and the internal mammary nodes, as well as any intramammary nodes, are also regional nodes. Any other node besides this is a non-regional node, and hence will be considered the distant metastasis as in M1 disease. That node involvement is the single most important prognostic factor that influences therapeutic decisions. Hence, the identification and processing and grossing of the node is very important. So, what kind of specimen can we receive of the regional lymph node? Generally, we receive the sentinel lymph nodes, in which the intraoperatively or preoperatively using dye or radio tracers, the dye is injected in the tumor, and the first draining node is the sentinel lymph node that is sent to identify the first station of metastasis of the tumor. If that is negative, generally the rest of the axillary fat is not sampled. Similar kind of utility has been reported by, instead of using dye or radio tracer, which is expensive, a more cost-effective method is low axillary sampling, in which the surgeon samples the level 1 fat, and it does not need any kind of intraoperative dye labeling, so it is more important in a resource constrained setting. Besides this, of course, we received axillary clearance on internal mammary nodes and other nodes as may be considered important. So how do you process the axillary fat? You have to serially slice the axillary fat medial to lateral and fix it as we have discussed for the mastectomy. Once the tissue is fixed, you have to dissect the nodes, and again palpation here is very important to identify the nodes. You have to identify the largest node and along with what the cut surface is showing. Now adequacy in axillary nodes is minimum of at least 10 lymph nodes should be sampled. So this is very crucial. If you have less than 10, please go back and sample the axillary fat, and if no additional node is identified, you should entire fat should be submitted to identify any microscopic nodes. The only condition where this requirement is relaxed a bit in some situations is in a post chemotherapy settings where the nodes are less easily identified. So how do you process the sentinel node? You have to bisect the node, or depending on size, and serially slice it at 2 mm intervals and submit one lymph node per block. We should always remember to submit, we should not strip the lymph node of the perinodal fat, but submit at least some amount of perinodal fat rim around the lymph node to document the presence of extranodal extension. If the nodes are very small, less than 5 mm, we can bisect and submit the entire node in one block. And if there's a grossly positive, like huge nodes, 3, 2, 3, 4 centimeter, we need not submit the whole node. We can give one section through the full face of the metastasis, and with gross documentation of the size of the metastasis, including we should try to give a section from any area that is suggestive of extranodal extension. Now, the importance of the size of the tumor in the node is that for the AJCC classification, the largest contiguous focus of the tumor is used, which we can classify it as micrometastasis, which are both considered as N1 disease or at least end staging disease. However, isolated tumor cells, that is, if we have less than 2 mm or less than 200 cells in a section, it is considered ITC, which is not staged as N disease, as N positive status, but as NITC. It is not considered a positive node. Now, we have to remember that this dimension includes any metastasis that is present within the lymph node, or even if it is extending out of the lymph node, or if it is present completely out of the node and present in the axillary fat. If it is more than 3 mm, it is considered a lymph node involvement with extranodal extension. Now, just to give a little brief overview about post-neoadjuvant chemotherapy specimen evaluation. Now, increasingly, we are seeing in the breast cancer patients, because of the presence of core biopsy, biomarker evaluation is available upfront, and the clinician takes a decision to give neoadjuvant chemotherapy and to do the surgery after that with multiple benefits, including ease of surgery, limiting the tumor size, making the tumor less vascular so that it's easier to resect. And the pathological evaluation of such specimen is considered the gold standard for evaluation of the extent of response. The clinical tumor regression or radiological regression does not correlate with the final pathological response, and only the pathological evaluation is considered the gold standard. However, it is very challenging for the pathologist to evaluate such specimen, but because of the effect of chemotherapy, the tumor becomes very soft, irregular, ill-defined, with presence of therapy-related changes, fibrosis, necrosis. So the tumor bed becomes difficult to identify, and similarly, the axillary nodes may also become softer, atrophic, more difficult to identify. So these are the various types of responses that we can see on the gross evaluation. When there is a very good response to the therapy, we might not identify any kind of gross abnormality, except maybe a little bit of hemorrhage here and there, or we might have a small focus of fibrosis, and both of these on microscopy might not show any kind of tumor. In the partial response to the chemotherapy, it can be in a concentric manner, whereby the tumor shrinks and the cellularity is the same, but the tumor becomes shrink and surrounded by ill-defined area of fibrosis. Or you can have a tumor with similar size but reduced cellularity. Or you can have what is known as a buckshot pattern response, in which different areas of the tumor respond differently, and because of this heterogeneity of the tumor, you might have a tumor bed that looks very ill-defined, irregular. So the assessment of the response or the tumor regression grading, there are multiple scoring systems available which have shown correlation with the final the assessment and prognosis. However, the most commonly used ones are the AJCC system or the residual cancer burden system. The AJCC system is the same as what we use in the TNM staging, except we add a prefix Y, and the T and M criteria remain the same as in the upfront setting. The other system is the residual cancer burden, which is used at our institute. It is a freely available calculator that is available on the website, in which you have to feed in certain parameters. That is, what is the primary tumor bed area in 2 dimensions, the overall cancer cellularity is assessed on microscopy, and the percentage of the tumor that is in situ disease. Along with this, you have to put in the number of positive lymph nodes and the size of the largest lymph node. So they have developed an algorithm which, based on these parameters, gives the result or the score in the form of an RCB class, which from RCB class 0, that is complete response, to RCB class 3, which indicates extensive residual disease. So accordingly, the clinician can modify the post surgery therapy if needed. The major difference between the AJCC and the RCB system is the measurement of the T size. Now, in the AJCC, as I said, the largest contiguous focus of the tumor is the T size. However, in the RCB system, in the tumor size of the tumor bed in 2 dimension is the T size, because it might be having multiple scattered microscopic foci over a large area. This is used in the RCB system, while AJCC still sticks to the largest contiguous focus of involvement. So when the response is concentric, both the AJCC and RCB can have similar sizes. However, when it is more heterogeneous or in a buckshot pattern, as I showed, then the size of the AJCC and RCB, the T size might differ. However, both the systems have shown significant utility. So the actual use of which system depends on institutional practice, your oncologist, the kind of response they are looking for, which kind of system they follow. However, for the pathologist, we should try to convey the information so that whichever system is used anywhere in the world, they are able to feed in the data and get their answer. So we should try to give the focus of the largest contiguous focus size also, as well as the tumor bed size in a report, so that as per the system being used, we can of course use any of the system in our reports, but the information should be there so that whichever system is being used, the oncologist can put in the data and get the answer. So how to gross this specimen? We have to again identify the tumor bed, which might be, as I showed you, the gross images might be fibrotic and resemble in fact fibrocystic disease. So the location of the tumor bed in correlation with the radiological findings and the presence of any clip or any kind of suture or prior biopsy site evaluation and the clinical quadrant involvement. All that is very important to identify the tumor bed. We should try to give the largest two-dimensional measurement on the gross and submit the largest cross section with the oriented grid diagram with accompanying either photograph, radiograph, or diagram in the paper. And on microscopy, when we see these sections, we estimate the cellularity relative to the total tumor bed size. And if the tumor is extending beyond or is smaller than what we identified on gross, with the help of T-size reconstruction, we can make the tumor size smaller or larger on the microscopic evaluation. So this is the one slice of the post-chemotherapy specimen in which a small nodular concentric area of the tumor was identified with surrounding fibrosis. So the whole fibrotic area is submitted because if we have a buckshot pattern, the microscopic extent of the tumor can be much bigger than what we are seeing on the gross examination. So we give the whole grid of including the whatever grossly identified tumor and the surrounding area of fibrosis, and we make a grid diagram in which this representative sections are labeled with the orientation to the overlying margins or base or skin. Now, how much of the tissue to sample? This kind of sampling that is in the grid fashion is recommended by the big NABCG group because it saves times, the blocks, and accounts for the heterogeneity of the tumor response. When it is a small specimen, less than 5 centimeter size, it can be submitted entirely. However, the criteria given is that 1 to 2 tissue blocks should be given per centimeter of the pre-treatment tumor size, not the grossly identified size, not the post-treatment radiological size or clinical size, but the pre-treatment tumor size identified on radiology or clinically. We should give at least 1 to 2 tissue blocks per centimeter of this pre-treatment tumor size. For very large residual tumors, we can give 5 representative blocks of every cross section, and several such slices can be sampled, 5 sections up to a maximum of 25 blocks. And if the even after sampling, if in the first round of sampling, if we see that the microscopic findings are not matching the gross impression, whether if you're not able to identify the tumor bed on the microscopy as it has been described in the gross, or if the tumor is extending beyond the the sections, the edges of the grid that have been sampled, then we might need to go back and sample more tissue. The lymph node sampling is the same. So to end, I will just like to give the mandatory parameters which are to be included in the histopath report in breast cancer reporting, which we should begin with the type of specimen we have received, the laterality, the site of the tumor, size of the tumor, the histologic type, histologic grade, the focality of the tumor, the DCIS and extent of DCIS, the extension of the tumor involving the base, NAC, or the margins, lymphovascular invasion, margins in case of wide excision, regional lymph nodes, and if required, ancillary studies such as biomarker testing. So once again, I would like to thank the organizers and Dr. Borges for giving me the opportunity to kick off the Breast Cancer Awareness Month.
Thank you so much, Ayushi. That was well within the time that was allotted, and I think you have done a very thorough exposition of what normal histology is and how one should go about tackling the different kinds of breast specimens. I think there have been questions in the chat box, so perhaps Jayati would like to put them to you, and then maybe we can have a discussion.
So,
thank you, ma'am.
The first question was, what's the prognosis of closed margin in frozen section? Should we mention them, and how does it matter?
So that is what I said, that the closed margin, you can mention, yes, it is this much millimeter away within 5 millimeter, but it will not be, don't report the margin as positive. Positive margin is only if it is directly involving the ink. After that, if you have reported it as closed, the decision is of the surgeon if they want to revise the margin, but it is not technically a positive margin.
So, ma'am, while we are discussing margins, do we report separately the distance of invasive carcinoma from the closest margin and distance of DCIS from the closest margin?
In the microscopy, yes. Grossly, it might not be possible to identify, but in the microscopy, we do report them separately, that if there is any tumor, the distance, the margins are free of tumor, invasive tumor and DCIS, and if it is closed, then it is close to invasive, this much millimeter from the invasive carcinoma, or this much tumor distance from the DCIS. We do report them separately.
Okay. And
I have just one more question for Ayushi on the same, but Jayati, if you want to ask, please go ahead, and then I will ask the question.
So, ma'am, I was trying to ask if, like they say, 2 millimeter is enough margin for a DCIS. But if you think of the TDLU of a breast, it is like branches of a tree. And when DCIS occurs with lobular cancerization, so why this 2 millimeter thing? Like a margin can be at a 2 millimeter distance from DCIS, but even then there may be DCIS in the adjacent breast.
Yes, so that is actually very well known. The 2 millimeter thickness has been taken by the
Oncologist.
Astro guidelines have recommended a 2 millimeter distance, but it is well known that because of presence of skip lesions, or even as you said, the presence of branching of the duct, if the margin is even like, that is what I'm saying, the decision is of the surgeon. So whatever the distance, if it is within 5 millimeter, you should try to report, so that it conveys the impression that yes, it is possible that there is DCIS left behind in the breast, and this factor is actually well known to the oncologist surgeons when they are doing a breast conservation surgery. So presence of DCIS near the margins, they are aware that yes, it is possible that there is presence of DCIS left behind in the breast, and then they go for adjuvant therapy if required, or revision of the margin if they feel that that will be more beneficial to the patient.
Well, what I wanted to ask you, Ayushi, is why have they made a distinction between DCIS and invasive carcinoma? For invasive carcinoma, it is ink on the tumor, right? Or tumor on the ink, whichever way you want to look at it. Yeah. But why does it need to be 2 millimeters for DCIS? What is the rationale for that?
Ma'am, as far as I'm aware, it is the mainly their logic is that the invasive tumor, if generally it is in a contiguous fashion, the distance can be measured, and if it is involving the ink, it is involving. And the prognostically, when they have in the studies where they have assessed the distance, if from the 5 millimeter, 4 millimeter, 3 millimeter, 2 millimeter, 1 millimeter, in the one of the big studies, it has been seen that this distance did not have any prognostic significance of the on the invasive carcinoma. But when it was about DCIS, presence of the 2 millimeter was a better prognosis than compared to if it was within 2 millimeters.
It doesn't make sense, does it?
Yeah, it is. I think that is the Astro guidelines. I was
Yeah,
also.
I understand that, but I think it doesn't make sense. But what does make sense to me is why we talk about extensive introductory carcinoma, as being in some ways related to recurrence in the breast. Ultimately, all these margins are about what? Recurrence, local recurrence. Okay, so when we talk about why is it that extensive introductory carcinoma that's the 25% or whatever figure that there is, why does it actually correspond with increased local recurrence? And I think anybody who has actually felt breast, all of us do breast examination when we feel them with our fingers. Unfortunately, we fix, because of this issue of cold ischemia time, breast is being fixed almost immediately. But those of us who never worried about breast ischemia time once upon a time, because we never did ERs and PRs and all these things, will know one thing, that you cannot feel intraductal carcinoma with your fingers, because there is no fibrosis or desmoplasia along with it. Okay, so it is almost certain that if you have extensive intraductal carcinoma, that you're going to get a positive margin, because the surgeon cannot feel the intraductal carcinoma with his finger, and is quite likely to sort of excise a piece of tissue where there is no desmoplasia. So he's away from the infiltrative carcinoma, but he's very likely to contain. And that is really, it isn't the fact that you have so much intraductal carcinoma that there may be multifocality or anything like that. It is about touch. And once you have fixed tissue, your touch is very different than when you have fresh tissue. And I'm not suggesting that you shouldn't have fixed tissue. In fact, it is very important to have fixed tissue. But I'm telling you this: the problem with the surgeon. The problem with the surgeon is that he's not able to feel when he is actually operating that he has got intraductal carcinoma, because there's no desmoplasia, and it just feels like mammary tissue without any kind of abnormality. And therefore, he's very likely then to get positive margins. Intraductal carcinoma at the margins, not invasive carcinoma, but it is there. But I find that this, it's a silly thing, 2 millimeters for intraductal carcinoma and ink of the tumor. But I think that we are slaves to this kind of thing. Somebody does a few, 1 or 2 papers, and then it comes and ASCO says it. That's why you have to do it. But I don't want to belabor that point. There must be so many other things in the chat box.
Yeah. Second question is, why LVI is taken 1 millimeter away from the tumor? Why not within the tumor?
So the answer lies in the prognostic significance, because within the tumor, when it is expanding in broad front, it tends to destroy everything in its way. So you might have the tumor that is destroying the lymphatics or the vessels inside the tumor, but the significance once it is gone beyond the tumor, that is away from the tumor, if you are seeing LVI, that is when it is considered as a spread beyond or outside of the tumor, and that is where it is likely to go along to the lymph nodes.
Yeah, I think Ayushi has explained it well. In fact, it is extremely difficult to identify lymphatic embolization within the tumor, because you get so many artifactual spaces and other things that are within the tumor. This is true of almost any organ when you are trying to identify lymphovascular embolization. It holds true for the thyroid and so many other things. It's next to impossible to have an accurate thing, and you can't be doing all the time doing all these endothelial markers and so forth. And the way to identify lymphatic embolization outside of, and I'm talking about outside the tumor, is just look for a vascular bundle. And when you see a vascular bundle, a vein and an artery together, there is a lymphatic that is along with it. So don't even make an assessment of lymphovascular embolization unless it is all over the the place, until you identify this space in which there is a tumor that is sitting close to an artery or a vein. And that's the way the lymphatics go. The lymphatics are not just just everywhere. And this is also very useful when you're trying to dissect lymph nodes in the axilla. Okay, when you've got axillary fat and you're dissecting lymph nodes, if you see veins or vessels that are going there, just feel along those the vasculature, and you will find lymph nodes. And if you just lay that fat out like a screen, and you look for the vessels, you are going to be much more successful at finding these, because that's where the lymph nodes and the lymphatics go. They go along the vascular bundles. So that's something that I think the more you dissect, the more adept you become at doing this. Okay. I just wanted to ask Ayushi, because we're talking about dissecting of lymph nodes and so on. Do you remove the fat before you dissect nodes, or do you leave the fat attached to the breast when you dissect lymph nodes? What do you recommend?
Ma'am, removal of the breast tissue with so that we can serially slice the axillary fat also in a in a bread loaf manner and properly, and then we can fix it along with the specimen along with the the mastectomy, and then palpate it properly later. Because I mean the if you remove the axillary fat, from that direction where the breast is attached, the formalin can penetrate properly.
Yes, I agree. I think that there is a lot of people take off the fat. I don't even take off the fat after it is fixed, because if you have the fat in place, you are able to spread that fat much better rather than all these lumps of fat in which you are trying to scrabble to find lymph nodes. It's I guess it's everybody's technique. I don't remove the fat, yeah, even after it is fixed. Okay, but there are different techniques, and whichever works for you is okay.
Yes.
I have a question both to Ayushi ma'am and Borges ma'am. If you get a positive lymph node in mastectomy specimen and not LVI in the sections you have examined, would you take extra sections, or you wouldn't bother about that and just mention definite vascular invasion is not seen?
Ma'am, would you take the question or should I answer?
Sure, Jayati. You don't have to have, just because you have lymph node metastasis doesn't mean that you have to have lymphovascular embolization. Okay, lymphovascular embolization that's within the breast has got a different significance than, lymph node metastasis. Lymph node metastasis has got a significance, yes, for local recurrence as well as for distant metastases. LVI in the breast itself suggests that you are going to get a recurrence if you don't radiate the flaps. Okay, so that is a different thing. I know that there are some pathologists who look very hard to find LVI when the nodes are positive. Once the nodes are positive, why do you need to look for LVI? You look for LVI very carefully when the nodes are positive.
Exactly. When the nodes are negative, it is more important to identify LVI than when the nodes, if it is the other way around.
They have different, you have a different significance altogether
Yes.
for these two things.
Okay, the next question is the tumor bed size same as tumor size?
No. The tumor bed size, especially if you are talking in terms of post-chemotherapy specimen, the tumor bed size and the tumor size might be completely vastly different. Because, as I said, it depends on the extent of response. So, if you have a concentric kind of tumor, so the tumor size will become much smaller than the tumor bed. While if you have a buckshot type of response, then as per the RCB as I showed, the tumor can be scattered everywhere, and that total tumor bed size will be the tumor size also. But in AJCC, the largest contiguous focus. So, there is some discrepancy between the two systems, but generally the tumor bed size and tumor size does not mean the same thing.
So, ma'am, for post-NSCT specimens, most of the cases we see shows a buckshot kind of response. So, how do you stage those tumors? Like, do you take the largest contiguous focus as T size or the tumor bed size as T size?
So, as I said, we should in a report give both the information.
Both the information.
So that we give the largest contiguous focus measures this much, and the tumor bed size also we give, so that as per the staging system the clinician is using, they can make depending on the system that they are using, the information should be available from the pathologist side. They can take the decision accordingly.
We document both the information, but at the end of the report, we have to give a PTNM.
PT AJCC is as per the largest contiguous focus.
Largest contiguous focus. Okay. Next question was, what is multicentric tumor in breast?
Yeah, multicentric is more than 5 centimeter apart on different quadrants.
Okay. Next question was, do we need to grade DCIS and how does it matter?
Of course, we do need to grade DCIS similar to the way we grade the invasive breast carcinoma. The high grade DCIS has different prognostic connotations compared to low grade DCIS. Ma'am, would you like to add something to this?
No, I think that yes, it is. You have to grade the DCIS because only the high grade DCIS has some connotation for recurrence. The other DCIS, if you've got a low grade DCIS, I don't think that anybody worries about recurrence in for those kinds of tumors. But if you really have comedo DCIS, I think that's bad disease. It's as good or as bad, I think, as invasive carcinoma. So that needs to be graded, yes.
Next was, what is the significance of measuring the skin flap in a mastectomy?
Yeah. So this is actually a more of a theoretical question, because the skin flap measurement, basically we will try to just one second, I'm losing my train of thought. Madam, can you please help me here?
Yeah, this is. See, some people measure skin size, other people also measure the weight of a mastectomy specimen.
Yeah.
Now, the reason for doing this is that you have lost this much skin, okay? And you measure the mastectomy as well. This is really more important for the surgeons that they do it in the operating room. For us, it is about documentation, that you have had this much of the skin and this is the weight of the mastectomy. Because if they haven't done it in the operating room and they want to reconstruct the breast later, then they need to know how much skin has been lost and what was the weight of that mastectomy, so that you can use a suitable implant. But anybody who's a breast surgeon does this automatically when they are in the operating room. Okay, it's about documentation for us, but for the surgeons, it is more from the point of view of how they plan their subsequent or at the same time, the reconstruction.
Next question was, in case with previous excisional biopsy followed by mastectomy, which tumor sites should be used for staging?
So yeah, so that in such situations, the T size becomes, it is, we cannot stage it on once the excision is done, because in the excision, the amount of tumor that was the size of tumor, if it is reaching the margin, then it was not the complete size of the tumor. And in the mastectomy, we might not have, because of the therapy related changes and everything, and because of the prior excision and shrinkage of the tissue, whatever amount of tumor we are seeing, we cannot just add that to the previous wide excision tumor size and say this is the T size. So in such situations, it is not possible to give an accurate T size.
So I think that's all.
There was one more question.
Okay.
In case of tumor in close proximity to skin / involving skin with overlapping morphological features of skin and breast tumors, how to approach such lesions? What IHC should be done?
I think that is a whole separate talk altogether. I think it is going to be covered in the malignant lesion evaluation in the subsequent talks.
Yeah. So
Yeah, I guess that we should leave that for Dr. Chinoy or whoever is going to take that that thing. I have just one last question for you, Ayushi. I noticed that this is something that the Tata Hospital guys do, and I don't know whether anybody else does that. That you showed that you put a lot of formalin soaked cotton in between the slices. Okay.
Yes.
Why do you do that?
It's not just Tata, ma'am. It is where when I was studying in AIMS as a JR, that is a practice.
Yes, but I've never seen it done anywhere else in the world.
So we learned it the hard way, that if we used to put the dry cotton inside, as residents, when we used to put the dry cotton inside,
I'm not talking about why do you need cotton at all?
Okay.
Yes, that's what I'm asking. Whether it's soaked or dry, obviously is of no significance at all.
So that also, when we used to, if we put without the cotton, when we put the specimen back into the containers, sometimes the slices used to stick together and the formalin would not penetrate properly in those areas.
Yeah,
so
Ayushi, there is a way around this, okay? You have, you're slicing the tumor, right? Before you put your cotton and whatever else you're wanting to do, you're slicing the breast, okay? And breast is not like colon or anything else, which is, which is slippery, which needs to be literally pinned so that, it fixes the way that it should. Breast tumors are hard, they are, very firm, and they keep their shape in many ways, all right? So why do we not take out that whole tumor? Okay, you know where it is, because you can make an assessment of where that tumor is. You can take it out, you can measure it, you can do whatever you want with it, and then slice it thinly and put it separately into a pot. What is the objection to doing that? Then you don't have anything to do with cotton and all that sort of thing, and you get the most beautiful fixation that you can possibly get with no red areas because the fat often does not allow a tumor to get in. Ultimately, you're going to take these the sections anyway. You're going to measure those, the tumor, which you can anyway do when it is fresh. Why do you need to keep it, to measure it after? In any case, you're not going to be able to measure the DCIS because you can't feel it. Okay, so why don't you do that?
Yeah, I think maybe I'll try that in the next specimen and see the difference.
Try it in the next specimen. Actually, try it and see whether if you've got you want to do it as a research project. See if you are underestimating, overestimating, whatever it is.
Yeah.
Your tumor. So you measure it in the fresh state, okay, and keep it. You can take it out for some specimens and you can leave it for the others and see how your. Because I see absolutely no sense in this messy business of stuffing cotton in over there, and all the Tata guys do it. I never did it in my life when I was in Tata Hospital for all these years. Something has changed, after I left, and it is all this business of stuffing cotton. Okay, I don't know. Jayati, you stuff cotton?
Ma'am, we do fresh glossing.
So did we. So did we. And yes, I understand the need for fixation because of this ERPR and all, but if you're doing it fresh and not ERPR, I'm talking about, this time that you are talking about, that you need to put it, yes, put it immediately into formalin. But I think once you have put it into formalin and you are slicing it, just take the tumor out, measure it, nicely slice it very thinly and put it into a pot, and you'll see the difference. Okay.
Yeah, madam.
One last question from the audience, ma'am. Yeah. After mastectomy, if there's a recurrent tumor during chemotherapy, like after 3 to 4 cycles, and the surgery was done again, do we need to restage the tumor? And if so, can we use YPTMN?
I think you can use YP the grading system for that, because the patient has received chemotherapy. So the YP basically indicates that the measurements and everything that we are taking now, the TNM staging, is after chemotherapy. I just missed the question, that are you saying the tumor was excised before?
Yes, I think, ma'am, it should be RPTNM.
That is not for excision. I'm talking about only chemotherapy. Once it is excised, as I said, it is not possible to give an accurate T staging. So even YP is not feasible in that sense, and the T size you cannot accurately measure. If I think I've got the question right. I'm not sure.
And if there's a recurrence after the excision of primary tumor, it is recurrent tumor, not YP.
If it is within 3 to 4 cycles, it is not recurrent, it is residual tumor.
Okay.
generally the difference between recurrence and residual, that is the same, for all over the body. It is the gap should be around 6 months between the primary and the recurrence to call it recurrent, while generally within 6 months it is considered as a residual
Same
tumor.
Okay.
Yes.
So I think that's all for the questions. Ma'am, I have one more question to ask. Do we get fiduciary markers often in post-tenacity excisions? These days we are
What did
getting
you say? Do we get what?
fiduciary marker. These days, ma'am, we are getting a lot of breast conservation surgeries where the oncologist put a small gold
Yes.
ware
Yes.
inside,
Yes.
and they call us back to ask us if during sectioning the
Yes.
flap, did we discover the fiduciary marker?
Yes,
Because
so identify, you have to know first of all that that such kind of clip has been put in, clip or marker has been put in. It should be there along with your histopath requisition form so that you can look for it, because most of these markers, as I said, they're gold color. So it is, while serially slicing, it is even if it is there, you have to really hunt for it sometimes. And generally, they post chemotherapy specimen, it is the most important, because that is the site that will mark the tumor bed, even if you cannot identify it grossly. So knowing that such a marker is there is a big help, and you have to document that yes, we have identified the marker and sample the area around it.
okay. And sometimes it is really difficult to sample because it is embedded within the
Within
fibrotic
the
bed.
fibrous tissue, yes. So it's very thinly slicing, serial slicing, if you know the marker is there. And it is actually a big help to the pathologist, especially in the post-chemotherapy specimen if it is present. Actually, it is not done in most places because that small marker is very expensive. So it is generally affording patients only who are able to buy that thing for a marker while the biopsy is being taken. And presence of that marker is identification, and the sampling of that area is a very good for the pathologist to say that yes, we have adequately sampled the tumor bed.
Okay. I think that's all for the questions.
Very good. I think, Ayushi, you've done really a very thorough job. And I want to thank the audience for asking all these questions, and Jayati as